Now, in our fifth and final section, we will talk about the condition known as the dysphagia. Dysphagia is difficulty in swallowing. So we will talk about the dysphagia. What are the causes of dysphagia or difficulty in swallowing? How we can investigate this condition, and clinical examination and radiography. And then also we will talk about the test known as manometry and pH studies. So dysphagia is difficulty. This is difficulty. So wherever you see the word this is difficulty. Phagia is for the swallowing. So dysphagia is difficulty in swallowing. Ordinophagia is pain on swallowing. Ordino is for the pain. So pain on swallowing, difficulty in swallowing. Normal, this is the normal esophagus. That's the dysphagia or difficulty in swallowing. That's the appearance. Pain more marked if there are associated ulcerative lesions present, if there are inflammatory lesions and food passage, oral cavity, oropharynx, and esophagus. So dysphagia is difficulty in swallowing. Ordinophagia is pain on swallowing. The pain or ordinophagia is more marked if there is ulcerative lesion, if there is inflammatory lesion present that can cause pain on swallowing. Now, different causes of dysphagia. The pre-esophageal causes. Pre means before. So before esophagus, what are the causes that can cause dysphagia? The oral phase, disturbance in mastication or chewing the food, disturbance in lubrication, disturbance in motility of the tongue, defects of the palate. So it's important that food we ingest should be in proper shape or condition before we swallow it to avoid the dysphagia. If the food is not properly chewed or masticated, or if it's not properly lubricated, lubrication of the food or the bolus by the saliva is very, very important for easy swallowing of the food, and that if the lubrication is not effective, then we can have dysphagia. Then the mobility of the tongue again is very important to make that bolus that is easily ingested. If that is not there, so all these different defects can cause the dysphagia. Then lesions of the buccal cavity and floor of the mouth again can cause dysphagia because we cannot chew the food properly, and that can cause a dysphagia. Then the pharyngeal phase. Both these phases are retroesophageal. Before the food enters the esophagus, these phases are there. We have pharyngeal phase, and the pharyngeal phase is obstructive lesions of the pharynx, inflammatory conditions, spasmodic conditions, and paralytic conditions. All these are different conditions in which again we can have dysphagia. Now, some esophageal causes of the dysphagia. What are the conditions of the esophagus that can cause difficulty in swallowing? If the lumen is not of good size, normal size, if it's narrowed, that can cause dysphagia. In atresia, foreign body, and presence of stricture. Benign or malignant tumors. If the wall of the esophagus has inflammation, acute or chronic esophagitis, hypomotility disorders, hypermotility disorders, and outside the wall conditions like hypopharyngeal, diverticulum, and hiatus hernia. vascular rings, mediastinal lesions, cervical osteophytes, and thyroid lesions. So these are some common conditions that can lead to dysphagia. It can be in the in the lumen of the esophagus, which is the opening through which the food passes. It can be in the wall of the esophagus. It can be in the outside area of the esophageal wall, which can have mediastinal lesions, cervical osteophytes, thyroid lesions. All these different conditions can cause the dysphagia. Now, some investigations that can be done. History is important, whether it's sudden onset or it's insidious onset, slow onset, or they have some complications or they have this dysphagia before. So history is very important. Sudden onset, foreign body or impaction of food. These two are most likely causes if there is sudden or onset of dysphagia. Progressive type is usually the malignancy. Intermittent, sometimes it's present, sometimes it's not. Spasm or spasmodic episodes. More to liquid if there is dysphagia is due to paralytic lesions. More to solid and progressing to liquids is malignancy or strictures, and intolerance to acid food or fruit juices is usually due to ulcerative lesion. So very comprehensive, detailed picture of the history, importance of history in the dysphagia diagnosis, whether it's sudden, it's progressive, intermittent, more to liquids. First it was to solids, then slowly to liquids, or it can be to acid food and fruit juices. So different conditions of the esophagus can lead to different type of dysphagia. Progressive is mainly malignancy. When it's in the beginning, usually it doesn't affect. Slowly as it progresses, becomes bigger, it can cause more obstruction. Now the clinical examination of the patient, we should do examination of the oral cavity, because we have oral phase, we have pharyngeal phase, and then we have esophageal phase of dysphagia. So it's important we should look for oral cavity also. Oropharynx, larynx, and the hypopharynx, all these should be examined. This exclude pre-esophageal causes. So pre-esophageal causes we can easily examine by the oropharyngeal examination if there is any foreign body present or if there is any other abnormality. Lesions are present which can be ulcerative, inflammatory. We can easily observe them. Examination of neck, chest, nervous system is also done. Next, blood examination and esophagoscopy. Blood examination, hemogram for diagnosis, treatment of Plummer-Vinson syndrome to know nutritional status of the patient. Esophagoscopy can be done, which is direct examination of esophagus, permit the biopsy specimen, and flexible, fiber optic, or rigid. We already mentioned advantages, disadvantages, when we should use flexible, when we should go for rigid, and what's the difference between how cost effective is all that. So we can use rigid or flexible esophagoscopes. Radiography, X-ray chest, exclude cardiovascular, pulmonary, mediastinal diseases which can be a cause outside the esophageal wall. Lateral view of the neck, excludes cervical osteophytes. barium swallow, diagnosis of malignancy, cardiac achalasia, and stricture. So all these are different tests: X-ray, chest, lateral view of the neck, barium swallow can be done for the examination. Manometric and pH studies. Pressure transducer along with pH electrode and open-tip catheter is introduced into esophagus to measure the pressure in esophagus at its sphincters. To look for the pressure, we insert the transducer along with pH electrodes and open-tipped catheter to look for the pressure across the esophagus. Acid reflux measured by pH electrode measures effectiveness of esophagus to clear acid load. So we should also measure the pH. pH is the level of hydrogen ion that determines the neutral, acidic or alkaline pH, and it tells us if there is acid reflux, which is measured by the pH electrode, and it measures the effectiveness of esophagus to clear the acid load. Helps to find esophageal spasm are spontaneous or acid induced. So it's very important, we should look for this to find out whether the spasm are as a result of increased acid or due to the other condition or spontaneous. Some other investigations that can be performed, we can do the bronchoscopy for bronchial carcinoma, cardiac catheterization for vascular anomalies, and thyroid scan for malignant thyroid. So that concludes our topic of foreign body in the food passage, in which we tried to cover in detail all the foreign bodies that can be ingested accidentally and what are the consequences of those foreign bodies, what are the sites of lodgement of these different foreign bodies, and then we talked about another condition which is the dysphagia. Thank you for watching sqadia.com.